Okay, next speaker, it's Dr. Peter van Roessel, MD, PhD. He completed his MD at Stanford University and trained in psychiatry at Columbia University and the New York Presbyterian Hospital. At Stanford, since 2017, he directs a resident-run general outpatient clinic, supports resident training in both psychopharmacology and psychodynamic psychotherapy, and co-leads a new ketamine-assisted psychotherapy clinic. As Director of Clinical Research for the OCD Research Lab, he conducts clinical trials exploring rapid-acting interventions and neural mechanisms of insight and attentional control in OCD. He additionally collaborates with the SUPS Exploratory Therapeutics Laboratory and the Williams Lab on studies of psychedelic-assisted psychotherapy and precision medicine approaches in PTSD and depression.
Hi, can everyone hear me okay? Great. Well, thank you very much, Matthias, for the kind introduction and all of the biographical detail. I should say it's relevant primarily because in training in New York City, I had the privilege as an intern of having Dr. Rodriguez Carolyn as my chief resident, and so really grateful to be able to continue the work that I've been able to do under her mentorship and leadership of the lab here. I also mentioned that I work with Tricia Suppies and Shannon Wiltsey-Sturman, who we've just heard on a study of MDMA-assisted psychotherapy for PTSD. In hearing the talks today, I just want to acknowledge, I think, what many of you may perhaps be thinking, that there's just so much stuff happening in the world and so many new technologies and so much change in how we think about treatment and what treatment options might be. And so much of what we're talking about today, I think, is its future possibility. Not quite here are things we can do now, and I know a lot of people are really struggling with symptoms now, and all of these different options may feel kind of overwhelming. But I want to say, amidst all the anxiety about all this stuff that's possible, there's so much kind of excitement, and I think in particular, such exciting opportunities to try and see how medication interventions may really synergize with psychotherapy interventions and really help accelerate treatment in exciting ways. And that, I think, goes back to my first impressions of Carolyn, who really taught me, like, hey, maybe we don't have to wait for months for symptoms to get better. You know, maybe there are things we can do now that can really make things change. So I'm not going to talk about MDMA in any detail further, but I will talk about nitrous oxide. And I'll just show you the molecule here, very simple. The rationale for studying this really goes back to Carolyn's work in large part, as nitrous oxide is a dissociative anesthetic. It was discovered in the very end of the 18th century, first used as an anesthetic in dental procedures in 1844. And it's known as a dissociative anesthetic, a little bit like ketamine. It's also been shown recently to be a rapid-acting intervention for treatment of major depressive symptoms, or in major depressive disorder. It also has a really good safety and tolerability profile. So we don't have some, ketamine's also generally quite safe, but nitrous oxide doesn't have some of the blood pressure, cardiac accelerating risks that ketamine may have. And then molecularly, like ketamine, nitrous oxide is thought to work through the glutamate pathways and also through potentially the body's opioid systems in ways, again, that both of which speak to some of what we understand about the biology of OCD. So there's a hypothesis that glutamate signaling abnormalities are part of what drives the pathophysiology of OCD. And that actually goes back to work that Elias Aboujaoudi and Larry Karan, who really started OCD research here at Stanford, have done. And also there's evidence that opioids themselves might be helpful for OCD symptoms, again, going back to Dr. Karan and work at Stanford a couple of decades ago. So the last thing I'll say is that although nitrous oxide is one of a number of different kinds of rapid-acting interventions that we're considering, ketamine, nitrous oxide, psilocybin is something that many of you will be familiar with as a exciting psychedelic medicine for mental health conditions. recent work with nitrous oxide suggests that all of these interventions, or at least ketamine, psilocybin, and nitrous oxide, may be converging on a particular population of neurons in the prefrontal cortex that are involved in the circuits that may drive OCD. So exciting evidence for sort of shared pathways through many of these different interventions. So that's the rationale. The study I'm going to show you is one I think those of you who've come to these meetings before have heard me advertise and ask for participants for. It's still ongoing. It's a proof of concept study looking at inhalation of nitrous oxide versus a control condition of just inhaling air, where we're trying to estimate effect sizes. Does it work? And if so, by how much relative to control? And are there markers in the brain or in the physiology of the body that we can measure that show that nitrous oxide is doing something relevant to OCD? So just to describe the study flow briefly, we first start with a screening process. We have looked and are still recruiting adults with primary OCD between 18 and 65, not currently using other medications. But in that sense, we also do want people to have had a chance to try or refuse a first-line treatment like exposure and response prevention psychotherapy or a serotonin reuptake inhibitor. The study is not open to people who may have psychotic symptoms, things in the nature of schizophrenia or schizoaffective disorder. It's also unfortunately not approved for people with bipolar disorder as a comorbidity, with active suicidality, substance use disorders, or vitamin B12 deficiency, which is a specific concern in terms of exposure to nitrous oxide. So people who enter the study are randomized. There's a twofold chance, or you're twice as likely to get an active inhalation of nitrous oxide gas mixed with high-dose oxygen. And 1/3 of participants are randomized to a placebo condition, which is essentially medical air in a tank combined with high-dose oxygen. And the device we're using, you can see here, is just a little breathing apparatus on wheels. It's a fixed dose. There's no way you can make a mistake essentially and give the wrong gas. It always gives 50% oxygen, which is greater than room air oxygen, alongside the study gas. And essentially, we ask people to just hold the mask to their face and breathe for an hour through the mask. So before, about a week before, and then at day 1, 3, 7, and 14 afterwards, we assess symptoms with the common rating scale for OCD called the Yale-Brown Obsessive Compulsive Scale, or the Y-BOX. We also look at symptoms of depression. We ask people subjectively about the severity of their experience of OCD symptoms. And we are also looking at measures of awareness of symptoms, something called BABS. In addition to these, we are doing some computer-based testing of cognitive functions, so performance on tests of attention and memory. And we're also have been recording brainwave activity using something called EEG during performance of a task. And I'll tell you a little bit about some of that data. So, and then we're also just measuring at least one blood marker that looks at that we think is an index of opioid system engagement. So just to say, this is all very preliminary. The number of people in the study is very small so far. So we've randomized 12 people to nitrous oxide. We've randomized 8 people to get placebo inhalation. This comes from a population of about 130 people we've screened for the study. And although we're excited to have this many participants so far, it's still a very small number. Randomness is a thing in clinical trials, and so one has to be quite skeptical about results and careful about interpreting results that come from really small studies like this, particularly ones also where the number of people in each arm is imbalanced, as by design this study is. That said, I'm really excited that we've recruited a very diverse and balanced sample. So the age is roughly similar between both groups. The distribution of gender and ethnicity is similar. Severity of Y-BOX excuse me, is similar between both groups, as is level of depression, and also the level of treatment resistance. So our patients generally have moderate to severe OCD, not very depressed, and most have tried serotonin reuptake inhibitors, and more than half have tried exposure and response prevention. So people are also moderately treatment resistant who've been doing the study. So one of the first things we ask about any novel treatment is, what's it like, and is it okay? Is it safe, and do people feel all right getting it? And so that's one thing that I think is very positive about nitrous oxide. That's thankfully as expected given prior research, and it's generally well-tolerated safety profile for use in dentistry and midwifery and things. Most of the side effects that we've seen are relatively mild and relatively generic. Dry mouth comes from breathing air that's not humidified through a mask. Many people do have headache, some fatigue and nausea, but you can see that these things are equally common in the placebo arm, and probably related to getting up early in the morning to get to our study without having eaten, things like that. There are some restlessness you see is higher in the nitrous oxide group. Nausea is a known side effect of dissociative anesthetics like nitrous oxide. We haven't seen that too severely, but it certainly can happen. So I also don't want to be dismissive of the chance of having adverse effects to nitrous oxide. In line with that, we also have looked at what's called dissociation, which are symptoms of, you could say, a different experience of yourself in relation to sensory processes, your perception of time, your perception of your body, your perception of vision, for example. And this is something that can be very distorted under dissociative anesthetics like ketamine. And we've seen that sort of altered mental status experience of nitrous oxide is relatively mild. So on average, there's not a significant difference in terms of dissociative symptoms between the experience of breathing nitrous oxide at the dose we're using, I should say. It's lower than might be used in other contexts. That said, there are a few individuals who have had significant dissociative symptoms, but on average, it's generally mild. So in line with that sort of good tolerability and not very potent psychoactive effect of the dose we're using, the blinding in the study was pretty good, which is to say that people who got nitrous oxide correctly guessed it about 60% of the time, and people who got placebo correctly guessed it about 1/3 of the time, which is in line with the randomization, where 2/3 of people were getting nitrous oxide, 1/3 placebo. And this is something that can give us more confidence in the results of the study, and that people aren't necessarily aware of what they had, and that helps us sort of assess symptoms more objectively without concern as much for expectancy effects, people's tendency to get better when they think they've had something that's going to work. So here are the primary results. So this is Y-box change, and you can see from left to right, this is going from baseline through to 2 weeks out to day 14. The top line at 0 is just the sort of average starting place for both groups, and you can see the reduction in the Y-box score. One thing you'll notice is a very strong placebo effect. And I think this is something all of us doing work with rapid acting interventions or psychedelic interventions have to consider, that people have a lot of expectancy about the treatment generally. And the experience of doing this kind of an intervention is intense. And you can see that on the day after, people reported a substantial impact in benefit in terms of the experience, although not necessarily different between the two arms. However, as time goes forward by day 3, and then day 7, day 14, and in fact, if you look at this dotted line, which sort of subtracts the placebo arm away from the nitrous oxide arm, you can see that there's a growing sort of significant effect of nitrous oxide, such that by day 14, there's a statistically significant difference with a relatively large effect. This G of 0.76 is a measure of what we call effect size, and generally considered to be moderate to large effect. Another way of thinking about it is that at 2 weeks out, 5 of the 12 people who received nitrous oxide met criteria for what we call a response, which is a 35% reduction in Y-box. Relatively good for a single intervention and a relatively treatment-resistant group, although of course we want to help the other 7 as well. So one thing that you can also see in this data, again, very preliminary, a small number of people, but that the effect on obsessions, the intrusive thoughts, images, urges, as Carolyn described earlier, seems to be greater than the impact on compulsions, which are those behaviors that are done to neutralize distress associated with obsessions. Whether this will hold out as we increase the number in the study isn't clear, but at this point, it's an interesting distinction between sort of these mental phenomena and the behaviors themselves. So I told you that we were looking at EEG right before and right after, and some cognitive tasks. And I want to just talk very briefly about this idea of trying to find a biomarker, something that changes in the brain in response to the treatment that gives us sort of more more confidence that we're doing something that's intervening with circuit or with activity in the brain that's relevant to the disorder. And so one thing we're looking at, or we looked at, is incongruity or conflict processing. And you can see the panels on the left, these are just examples of different kind of tasks or games that we might ask someone to play that involve this idea of conflict. So the top is called a flanker task. You can see 5 arrows in a row. The middle arrow points in a different direction than the flanking arrows. And we would ask a person in this task to click a right or left button in response to the direction of the central arrow. If you see the red word printed in blue, this is a task where you might ask someone to name the ink color. And you can see how both involve a stimulus conflict, and the brain has to sort of resolve this ambiguity of this conflict. And so why are we looking at this? Well, there's a lot of data that would suggest that the brain's response to mistakes in these kind of conflict situations is greater in individuals with OCD, and also in their relatives. That's what's meant by an endophenotype, or kind of a predisposition, and perhaps a condition that leads to the likelihood of OCD. There's data suggesting that some of these tasks, that red-blue Stroop task in particular, performance on that may relate to how people respond to treatment in OCD. And then a particular interest of mine is how people come to know that there's something wrong, that they're having obsessions, that they're having compulsions, that there's something, that there's a psychological illness, and that degree of illness awareness, or what's considered insight, there's good evidence to suggest that that's related to awareness of error, awareness of conflict. And so for this reason, it's something we wanted to study. So I remember back from grad school, the supervisor who said, anytime someone puts a waveform on the screen, I go to sleep. So I also realized we're close to the end of the talk. So just to describe this briefly, this just describes the EEG experiment we do, where we record electrical activity at the scalp. And you have to do this a bunch of times over a discrete event. And the event here is people looking at a sudden flash of these arrows on the screen and clicking a mouse as to left or right. We're actually not looking here at what button they click or whether they get it right or not. We're just looking at what happens in the brain when that image flashes on the screen. And if you average that a whole bunch of times, you can see these 2 arrows at the top, or these 2 waves at the top. The blue is what happens when the arrows all make sense. They're all pointing in the same direction. The magenta is what happens when all of a sudden one of the arrows is discrepant or incongruous with the other arrows. And then you can subtract the 2 of them and get this waveform below in, I lost my mouse here, but in red. And that waveform is essentially the brain's response to incongruity, or the brain's response to the stimulus conflict. Excitingly, when we look before and after nitrous oxide versus before and after the placebo condition, you can see in the waveforms, but more easily in this graph, that signal of incongruity seems to be turned up, like we're kind of turning up the brain's sensitivity to conflict after nitrous oxide versus after placebo. So we think that nitrous oxide may enhance that incongruity signal. And this is a little also complicated, but here you're looking at sort of color maps of activity in the brain that we can measure with EEG. And you may be familiar with the idea of brain rhythms, or sort of wavelengths. There's a particular rhythm called alpha rhythm, which is happening about 10 times a second. These clusters of neurons that are speaking around that frequency, and you can see that after an incongruent stimulus, after nitrous oxide, not after placebo, you get this sort of downregulation, or this sudden dip in the power of that resting alpha frequency. And we think of that, or it's described in literature as a sort of event-related desynchronization. So that alpha pattern is something that's active in your brain when you close your eyes or when you're at rest. But we think there's something after the nitrous oxide that allows that brain, and you can see here, primarily over the front center, over the central area, that we think may reflect sort of motor planning and motor responses. There's something that's sort of freed about that area of the brain after nitrous oxide that doesn't happen after placebo. So just to conclude, so far with our small sample, we've seen that nitrous oxide is well tolerated with mild, if any, dissociative symptoms. We see a large effect at this point on OCD symptoms at about 2 weeks out from a single 1-hour inhalation of nitrous oxide. There's some suggestion that the intervention may have a greater impact on obsessions and compulsions, and that it may enhance the neural processing of incongruity. I'm thinking back to what we just heard from Kira about that idea of sitting in a box with a snake, right? The snake means death, but I'm not dying. There's something incongruous about that. And does this sort of incongruity signal help me learn in those situations? So I'll just jump from that observation down to the last of the next to explore here, the impact of nitrous oxide on exposure therapy outcomes. Clearly, this is just a drug study, right? We're just doing the inhalation here, not looking at therapy. But I think one of the really great questions is, can a treatment like this somehow influence how people respond to a psychotherapy afterwards? And I think our next steps would be to try and merge this sort of intervention with psychotherapy in ways that we're starting to do now with MDMA-assisted psychotherapy. So well, I'll wrap up there and join the other panelists perhaps for some questions.